Hey everyone, and welcome to this explainer. I am literally so thrilled to have you here today because we're going to demystify a tool that absolutely everyone has encountered at some point. Usually while leaning back in a big chair under a blindingly bright light. Yep, we're talking about the Dental Explorer. My goal today is to completely flip how you view this little metal instrument. By the time we wrap up, you won't see it as some medieval torture device to dread, but actually as this absolute marvel of clinical engineering and tactile precision. Okay, let's dive into this. We all know that distinct feeling, right? You're at the dentist, you open wide, and you just brace yourself for that sharp little metal hook to start scraping and sometimes poking directly into a super sensitive spot on your tooth. Ouch. For decades, this was literally the gold standard of care. Dentists actively use the Explorer to probe teeth really firmly just to check for the presence of cavities. But what if I told you that our modern understanding of this tool has completely shifted? So think about this comparison. Back in the 20th century, that firm pressure probing, totally normal. But in the 21st century, dental professionals have really started to heavily question that practice. Why? Well, because using a sharp explorer with firm pressure can actually cause cavitation. That means it can literally rupture the super thin surface layer of a tooth that's just starting to decay. You see, early dental lesions develop beneath the surface, and as long as that surface layer stays intact, the tooth can actually heal itself. It can remineralize with good oral care and fluoride. Jabbing it with a hook completely ruins that chance. So today, the clinical recommendation has shifted way more toward sharp eyes, blunt probes, and cool non-invasive tech like laser fluorescence to spot decay. It's all about saving that tooth surface. So here's our roadmap for the explainer today. We're going to cover the controversial dental hook, anatomy of the 1112, the art of the stroke, avoiding the death grip, subgingival exploring steps, and finally, clock positioning. Section 1. The controversial dental hook. From poking to precision. All right, we're moving our mindset away from that outdated fear of poking and into the modern reality of extreme precision. While we usually call it an explorer, its technical name is often a sickle probe. It's a tool frequently utilized in the dental arsenal, and yes, it is designed with a sharp tip. But here is the major perspective shift. That sharp tip is not designed to inflict pain. It's not meant to forcefully dig into your enamel. It's specifically designed to improve tactile perception. You've got to think of it less like a pickaxe and way more like a highly tuned antenna that essentially extends the clinician's own nervous system right into your mouth. Wild, right? Now, before we get to the real star of the show, it's definitely worth noting there are a few variations of this tool out there. The most common one you might recognize is the number 23 Explorer, which is lovingly referred to as the shepherd's hook. There's also the 3CH, which kind of looks like a cow horn or a pigtail, and the number 17, which is super useful for those really tight interproximal areas. The space is right between your teeth. But among all of these, there is one undisputed champion for the dental hygienist. Section 2. Anatomy of the 1112. The hygienist's masterpiece. Experts actually consider this specific instrument to be a hygienist's single most important tool for detecting calculus, both above and below the gum line. And this brilliantly illustrates why. The 1112 is double-ended, featuring exact mirror image working ends. Plus, its tip sits at a really precise 90-degree angle to the lower shank. Because of this incredibly long and intricate shank design, the tool is universally adaptable. It is equally useful whether your hygienist is working right up front on your interior teeth or reaching way, way back to your posterior teeth, even deep down in periodontal pockets. And that 90-degree angle, it isn't just for show. It serves a really vital protective function. The design lets the clinician apply the back of the tip safely to the base of your gum pocket. That means they can slide the instrument all the way down without lacerating the junctional epithelium, which is just a fancy term for that delicate tissue connecting your gums to your teeth. It perfectly adapts to absolutely every single tooth surface throughout the mouth safely. Section 3. The art of the stroke, the biomechanics of assessment. So this is where the physical tool magically translates into a sensory language of vibrations. Now, what's really interesting about this criteria is that it entirely removes physical strength from the equation. When you look at the mechanics for the assessment stroke, which is also known as the exploratory stroke, the grasp absolutely must be relaxed. The lateral pressure against the tooth, feather light. The clinician really only adapts the side of the tip, just the tip 1/3, which is roughly 1 to 2 millimeters. They use fluid, sweeping, overlapping, and multidirectional strokes. They aren't trying to scrape anything off here. They're actually feeling for tiny, unseen anomalies like grainy deposits of calculus. They completely rely on tactile sensitivity to feel tiny vibrations transferring from that tiny tip all the way up the metal handle and right into their fingers. Section 4. Avoiding the death grip. The danger of tension. Okay, I want you to imagine holding a pen and squeezing it so tightly that your knuckles turn completely white. We've all done it, right? Well, in dentistry, doing that is a known critical error called the death grip. It happens when a clinician uses this super tight, tense handling of the instrument, literally blanching their fingers at the joints. Specifically, it involves pressing the middle finger way too hard against the instrument's shank. This is a huge problem. Listen to this crucial quote from the clinical text. This disables the tactile sense needed to feel for the irregularities on the root surfaces. When a clinician tenses up, they essentially numb their own fingertips. By pressing that middle finger too hard against the metal shank, they actually block the tactile information from traveling up the tool. So a feather-light grip isn't just some suggestion for hand comfort, it is an absolute biomechanical necessity if this tool is going to function as a diagnostic instrument at all. Section 5. Subgingival exploring steps beneath the gum line. Without this precise tool, a clinician is honestly just guessing if they've actually removed all the hidden calculus deposits. So they need a really systematic approach. Let's see how this builds into a highly methodical procedure. Step 1 is adapting that tip 1/3 and sliding it carefully beneath the gingival margin. Step 2 is reaching the base of the sulcus, and the clinician knows they're there because the tissue suddenly feels soft and elastic. Then, step 3 is beginning the stroke in a coronal direction, which basically just means moving upward along the root. Step 4 requires immense control, keeping those strokes to just 2 to 3 millimeters so the explorer doesn't accidentally pop right out of the pocket. Step 5 is fascinating. They actually mentally section the tooth into apical, middle, and cervical zones to ensure absolutely nothing is missed. Finally, step 6 tackles those super tricky proximal surfaces, leading with the tip to reach halfway from the front and halfway from the back. It is a completely comprehensive, microscopic sweep. Section 6. Clock positioning for clinicians. The geometry of dentistry. To execute all these microscopic steps properly, the clinician's body actually has to be perfectly aligned with the patient. Think of the dental chair as a giant clock face, with the patient's head resting right at 12 o'clock. There are incredibly strict spatial rules required to properly adapt the 11-12 Explorer. For right-handed clinicians, if they're working on tooth surfaces facing toward them, they have to sit precisely at the 8 to 9 o'clock position. For surfaces facing away, they shift over to the 11 to 1 o'clock position. Left-handed clinicians have their own mirror geometry. They sit at 3 to 4 o'clock for surfaces toward them, and then join the right-handers at 11 to 1 o'clock for surfaces facing away. This isn't about ergonomics or comfort. It is a fundamental, non-negotiable requirement to keep the terminal shank parallel to the tooth's axis. And that brings us to the end of our explainer today. We've gone from fearing a terrifying hook to exploring a masterclass in featherlight biomechanics, complex instrument anatomy, and rigid spatial geometry. It really leaves us with a provocative thought. Just how much unseen precision goes into your everyday healthcare routines. The next time you're sitting back in that dental chair and you feel that tiny vibration against your teeth, you're going to know exactly the silent, tactile art your hygienist is performing. Thank you so much for exploring this with me today. Keep asking questions and always keep seeking to understand the world around you.